It was the day that I was inserting a large dialysis catheter into someone's neck who was dying. And I knew she was dying, but still, I'd been asked to put this dialysis catheter into her neck, so that was my job. And I looked up after I had assembled the entire sterile field and I was getting ready to insert this catheter, and I looked up and saw this nurse, Pat Murphy, who was the head of the family support team, palliative care nurse, although, again, I didn't know what palliative care was. And she was standing in the doorway and she just looked like disgusted. And she looked at me and she went like this. She said, you know, call the police. They're torturing a patient in the ICU at University Hospital. And I mean, I was terrified and freaked out, not because I thought she was going to call the police. I knew it was a pretend phone, but I realized that these feelings I had been having, that had been gathering about hurting people, that she was right, that I was doing something that I didn't really think was in this patient's best interest. And it made me feel like I was a bad person, but I was just doing what I'd been trained to do. And I was filled with conflict and stress, but I am not proud to say I ended up putting that catheter in that day. But from then on, and that was a real turning point for me, I sort of vowed to do my best to practice in a different way and to really not assume that people always wanted these types of treatments that might support organ function, but to really talk with them on a deeper level about who they were, what was important to them, and how did they want to live. For the lay community, I would say, number one, accept that death is going to happen at some point, and start making preparations much earlier than the intensive care unit, than when you're in extremis in the intensive care unit. It is not a good place to be making these types of decisions. It really is important to have some familiarity with what's important to you and to have talked about it with your loved ones before you get into that situation. I mean, as you can see in the movie, many times people really can no longer speak for themselves. And it's really important that some of you and your life preferences has been dispensed out into the world, whether it's with your family or with your physician. So really accept mortality as a fact and start to do some preparatory work earlier than when you become very seriously ill. Some people even do it yearly on their anniversaries. They play, for example, Go Wish, which is a great card game that helps people really prioritize what's most important to them. And that gives their family members really valuable information. But there's many other things that people can do to prepare. And the last thing for the lay audience is to say, really expect communication from your healthcare team. If you're not getting information that's helping you, then you need to ask for it more forcefully, more supportively also, and say, I want to know what you're thinking. I want to understand what you're thinking. Say that to the physician, because that gives them permission to be more honest with you. Physicians are people too. It's very hard to break bad news. I would also say, that physicians need to support each other. It's really hard. I find it very hard, and I know many of my colleagues do, to talk about changing goals of care from full court press to possibly offering a different option to a family. That's very, very hard. It goes against our training. It goes against our feelings of success, because we feel successful when we're treating or trying or curing. Sometimes people die, and sometimes people are dying, and the doctors know it. We've got to change our ideas of what is success as physicians, and it shouldn't just include curing somebody. For the non-physician healthcare provider, that's a whole different role. They have a really important role to play, and we're not tapping them yet. Nurses, social workers, chaplains, nutritionists, anybody who has contact with a patient has information that might be helpful to the doctor who's currently the person making the decisions. That may change in the future. I'm much more of a collaborative type of person, and I believe there shouldn't just be this one lone warrior doctor at the top making all the decisions. I really think this has to be. These are too emotionally difficult, and I think doing this more by collaborative approaches is better. But for now, since we still are in a hierarchical mode, I would ask and expect nurses, social workers, chaplains to step forward, and even though it's difficult, to put their feelings forward, to make a case to bring forward new information, and to step up and speak up.